Just a little background, I primarily treat breast cancer radiation as well as sarcoma at the clinic, on top of being the director of clinical research. And this really is our foray into SGRT, and it really is a testament rather than to myself, to my team. And that team really includes the people who led this charge, which were my therapists on our machine that treats primarily breast cancer, as well as our physics team. And you'll be hearing from one of our physicists in a little bit. So just as disclosures, I'm a consultant for ImpediMed, and I do have grant funding. So to kind of talk about how our program was built before and after we incorporated SGRT, I think it's important to understand kind of what we're doing with respect to breast cancer radiotherapy. As highlighted previously, radiation is vital in the management of breast cancer. And we treat women who undergo lumpectomies, women who undergo mastectomies, and women with recurrences. There's a lot of different options, and really it's a changing set of indications. Every week, every month, I am given a new set of guidelines and theory to think about how to treat breast cancer radiotherapy. And so the question is, how do we incorporate new technologies into an area that's already becoming more and more complex? And this slide on the right basically is a paper from one of my residents comparing how many different radiation options we now have. 10 years ago, it was really easy, my job. I got to go in and say, oh, you're going to have 5 weeks of radiation, have a good day. Unfortunately, my discussion has to be much longer now and goes the gamut of no radiation to intraoperative radiation all the way to 5 or 6 weeks of radiation. So the Cleveland Clinic Breast Radiation Program, I'm going to break it up into what we do for breast conservation as well as mastectomy. As I said, we offer the gamut. We do still offer standard fractionation for a limited number of patients, typically those that are very young, those that are node positive, and those who, for some reason or other, we can't get the max hotspot under 107%. We do offer primarily hypofractionated whole breast, which would be the predominant modality that my team uses. We do accelerated partial breast. We do brachytherapy-based 5-day treatment. We do external beam-based 5-day treatment using IMRT. And we do 2-day partial breast on clinical trial. We also do intraoperative radiotherapy for low-risk patients. And the reason we offer these is, to be forthright, is it's all about what the benefit is. So when you look at these studies all put together, radiation therapy reduces the risk of local recurrence, which is great, but more importantly, it improves survival. So it decreases the risk of dying of breast cancer, and it decreases the death rate overall with long-term outcomes. So that really is the penultimate goal of any oncologist, is to improve survival, and we can say that with breast cancer radiotherapy. So what do we do with respect to post-mastectomy radiation? We haven't made as many evolutions here, and so we're still using standard fractionation for the most part, with or without inclusion of internal mammary nodes. And we are considering hypofractionation in select cases, going to 3 weeks when treating the chest and regional nodes. We use standard indications following chemotherapy, and with neoadjuvant chemotherapy, I don't think any radiation oncologist in the room will tell you we know exactly what we're doing, but hopefully in the years to come we'll have a better idea of who should be treated and who doesn't need to be treated post-mastectomy. And the reason, again, is very similar for post-mastectomy. When we look at the outcomes of all these patients put together, radiation therapy in this population improves survival. So again, I like local regional control benefits, but I really like survival advantages. And when it comes to patients, that's what we really want to drive home, is that we want to be able to provide this survival advantage while maintaining or improving on their quality of life and reducing toxicities. And part of that is knowing that what you're targeting is what you're actually treating. My patients ask me why a lot of the things we do on the machine for our breast cancer patients are done. I tell them that at the end of the day, the best way I can ensure a good outcome is by making sure what I plan to treat is what's treated every day. So our standard breast cancer protocol is a CT simulation supine. We very rarely treat prone unless for really large breasted patients who aren't getting lymph node irradiation. We use a breast board, we wire our borders, we wire our scar. And for left cases, we actually do a scan with and without ABC. We do ABC teaching and coaching. And typically, we've actually incorporated this into our paradigm, which is to actually make sure the patient can do ABC. So that often requires 5 to 7 breath holds at the time of simulation, because they may be able to hold it for 1 or 2 breath holds, but then when it comes to actually delivering on their treatment plan, we sometimes run into patients who can do it at simulation but not at treatment. So that's something that we've definitely added into our paradigm with some experience. In terms of treatment planning, we do primarily 3D conformal. We very rarely use IMRT with the exception of reirradiation cases where we're giving 100, 110 gray cumulative doses. And we use techniques, primarily tangents, field and field. Astro released a new paper 3 days ago that actually recommends that IMRT not be used and that field and field be the standard of care for whole breast radiation. For patients undergoing regional nodal, we use monoisocentric and in some cases dual isocenter for very long chest walls, or if I just want to move the match high so that I can reduce the lung dose. With respect to cardiac sparing, we fuse the ABC and non-ABC scans, and we actually do an overlay so that I can subsequently look at basically the left ventricle and see where it is in relation to the tangents. There is a subset of patients who unfortunately we don't see any heart motion with ABC, and for them simply doing ABC doesn't provide a benefit. We offer the primary technique, which is ABC with an additional cardiac block. There was a nice paper from North Carolina published 2 months ago which showed no perfusion deficits with this technique. The only key is that you have to make sure that your cavity and your chest wall where you are doing the block aren't underdosed and aren't relevant clinically. Alternatives that we've offered, prone, we offer cardiac block alone in some patients, very rarely IMRT, or in low-risk patients, potentially APBI. With respect to internal mammary nodes, we use partially wide tangents, and if the lung and heart doses get too much, we may consider an electron match over a partially wide tangent. So our breast volume, this is part of the challenge of incorporating a new technology like SGRT. We see over 500 new breast cases every year. So when it comes to incorporating a new technique or a new paradigm, as we have, there's a couple issues that come to mind. First of all and foremost is quality and safety. I'm not going to incorporate something into my breast program that's not going to provide increased quality and increased safety. I want to know about clinical outcomes and toxicity. I need to know about efficiency and use of resources. I only have so many resources at my disposal, and as much as I'd like to incorporate every technology, I have to be able to do it in such a way that it actually doesn't destroy my throughput, because we have a lot of patients to treat. And then patient challenges. I treat a lot of patients who come from quite a distance for cardiac sparing radiation. We have a cardiac oncology program at the Cleveland Clinic, and they may drive 60, 80. I have one patient who drives 110 miles each way every day to get cardiac sparing radiation. And so distance and cost is certainly an issue. So with respect to our implementation, we began utilizing Vision RT in the summer/fall of 2016. We'd had a system previously in place, but hadn't really been using it, and really at the charge of our therapists and our physicists, it was brought to my attention that we could be doing more for our patients, and that if we had the technology, we should really be incorporating it. We do have a unique system at the clinic in that we had a machine that was basically only for breast cancer patients, which is a nice luxury to have in the sense that we could do something that was systematically incorporated at one machine across the board and do one set of therapist education. And we initially added it on to our standard protocol in an IRB-approved fashion. So my therapist helped set up these next couple of slides because they can truly tell you what the learning curve is. I, as the physician, get the nice privilege of basically saying, let's do this, let's run with it, but then I gotta go. So I'm lucky enough to have wonderful therapists who were able to really take the ball and run with it. They tell me the learning curve was a couple weeks. Really just taking some time to learn how to do patient setups, putting in the ROIs, importing and doing patient positioning with yaw, pitch, and roll. To this point, actually, they are probably, and my physicists will highlight this as well, they are the experts and they're the ones that drive this program. And I think in that way it's really empowered patient care and safety because they've taken ownership and they feel like this is part of their responsibility to their patients. I think importantly for those looking to see what that impact is on treatment times, it's had no change in the length of our time slots for treatment. And some of the stuff that I'll talk about in a few minutes may actually reduce how much time it takes per patient. So in that sense, we're actually increasing efficiency while adding a quality and safety measure. In March of 2017, we opened a brand new cancer center at the clinic, so we didn't take any of our machines with us other than one Edge, so we were on all new machines in a brand new building. We started using Vision RT on day one on our brand new breast TrueBeam, which again, like the old department, had just one machine that was dedicated to breast, and it's primarily left breast cases because of the fact that they come to downtown for that reason. So to date, what we're doing is pretty straightforward. Vision RT is being used on all of our tangent cases, all of our monoisocentric cases. We haven't yet incorporated in prone cases just because they're rare, and 2 isocenter. We have done some tests and they are capable of such things. It's just we want to make sure we slowly incorporate things into our program because we do have such a large program. And the plan is to develop new workflow for these cases over the next probably 6 to 10 months to get all of our breast cases standardized. And subsequently, the plan after that is to consider incorporating this throughout all of our regional centers. So the Cleveland Clinic is, a large main campus center, but we have over 10 regional centers in Ohio and Florida. And so we're actually considering, will that be the next step in our paradigm? Because this has worked so well, can we really take this prime time into all our centers? And with respect to our experience, we've had it work in all our cases, and you saw what our patient volume is, with the exception of one which was more of a patient issue. So how do we use Vision RT in our daily breast cancer setups? So for all cases, Vision RT is used as part of setup. It's used for patient monitoring. I think one of the important things my therapist wanted to highlight was that during treatments, if a patient moves, we adjust between fields rather than during a field, so in a segmented case or a field-in-field case. Tangents, for patients having tangents alone, we're using it to align the patient and checking the medial tangent border for a match, as well as checking an SSD, and I'll show you some data with respect to that shortly. For monoisocentric cases, we're looking to use that to triangulate using the tattoos and then go to isocenter and use Vision RT for confirmation of alignment and to check the SSD. In cases where we do use ABC, we use the Vision RT on the inhalation breath hold and we monitor it during treatment. And obviously future studies and a future paradigm may allow us to actually eliminate the ABC portion and do the breath hold without. So in terms of comparing Vision RT and portal imaging, this is very raw data, really just for the point of edification, and my physicist will be going over this much more, but the ARC2 and TrueBeam 1 are just the 2 machines we had, one at the old center, one at the new, and what we're really, I think the bottom part of this is really the most important thing. So when Vision RT and ports and marks don't agree, which is more accurate? Vision RT. And I think that's really the key takeaway from all of this. And something that I'll be honest that I wasn't sure I would have believed just about a year ago. I was kind of a conservative, purist radiation oncologist, and I thought tangents and marks was the way to go, and I've been proven wrong by my therapist and my physicists. In terms of replacing manual SSD with Vision RT, this is something my therapists love and something we're actively pursuing because they can tell me how much they hate doing it the old way. And so I think this is really going to be the future for us, is moving into a more streamlined, efficient process, which is really going to make the patients, patients undergoing ABC, as I'm sure our patient that was here can tell us, you spend a lot of time on the table with an ABC patient, with breath holds, with setup. And so anything that can reduce that time on the table, and I think Vision RT is one of those things, will improve patient satisfaction and outcomes. So in conclusions, Vision RT was integrated into the Cleveland Clinic breast radiotherapy program. We saw no significant patient delays. We saw same or an enhanced throughput of workflow, which really is kind of, I think, a key efficiency standpoint. And my therapists find that it improves quality and safety, patient assessment during treatment, and patient engagement. I think one of the important things is I have patients who tell me that they want to come to our office even if it's distance away because they feel that the Vision RT adds another element of quality and safety to their care. So I have a lot of offices, and some of them still have ABC, but patients will say, I don't want just ABC, I would like this surface guided radiation therapy on top of ABC. And that's really a quality driver, and it's a patient satisfaction indicator. And they are willing to drive, and they are willing to wait to get that, which I think is pretty impressive. Our data to date demonstrates that SGRT correlates with portal imaging and offers the potential to replace SSD moving forward, manual SSD checks moving forward. So what are we doing at the Cleveland Clinic to move SGRT forward on our breast radiotherapy program? We're planning on adding the 2 isocenter and prone techniques, really to show a consistent delivery technique across the board. And the plan is then to potentially roll this out to all our regional centers. We've talked of changing the threshold from 3 millimeters to 5 millimeters because of traditionally breast fields are relatively large and we have some wiggle room, so to try to reduce some of that inefficiencies. We want to look at outliers and see which patients really struggle with meeting these thresholds and have a lot of movement, and can we pick those patients off and maybe engage in early education to limit how much motion they're having on the table and improve their outcomes. Potentially replacing ABC with SGRT based on evaluation of breath hold, and replacing manual SSD with Vision RT. And then we're doing image-guided external beam. It's based on a randomized clinical trial showing no difference with external beam IMRT versus whole breast radiation. It manages to cut the treatments from 15 to 20 to 5. And it actually is a cost savings to the healthcare system. Even with IMRT, it's cheaper than doing hypofractionated whole breast radiation therapy. So as part of incorporating this, we'd like to incorporate SGRT into our treatment workflow to allow for increasingly reproducible setups, smaller margins, and reductions in breast toxicity. I'd like to thank my team, and my team is quite large. I have the therapists on the breast machine, Danae McCarthy, Tracy Palmason, and all of the other therapists on those machines. Dosimetry, and one of the things that when we incorporated SGRT into our breast program is the therapists really made an evolving change. So every treatment plan now has a mark on it that says Vision RT so that the therapists and the dosimetrists have clear communication on these cases. I'd like to thank our physicist, Bing Chi, who's going to be speaking a little bit, and the head of physics, Ping Jia, who really was the driver of all of this. My nurse, Jessica, my residents and fellows, and then my two partners, Dr. Tendulkar and Dr. Cherry, who treat breast cancer with me, as well as my chairman, Dr. Su. And with that, I'll take any questions. Thank you. Please. So right now we have an IRB approved protocol, and we're actually looking at both. But the idea is if we continue to see consistent findings that we could potentially do that, yeah. And I think my physicist who's sitting right next to you is going to probably go over that a little bit in her talk as well. Any other questions? Go ahead.
I was just wondering what the dose was for the accelerated PBIs.
It's 30 gray and 5 fractions every other day. It's Livy et al. It's the University of Florence randomized trial.
You mentioned that you're going to change the threshold from 3 millimeter to 5 millimeter.
Mm-hmm.
Was that on the DIBH patients?
I think we were looking at across the board. When we talk about solutions in our program, we try to do things that are systematic because it's hard to change thresholds for some set of patients and not others. It makes it more challenging for the therapist. It makes it more challenging for creating, SOPs. So it's something we've talked about across the board for all our breast patients.
For some of our patients, especially towards the end of treatment, we see swelling of the breasts. How do you handle that with Vision RT?
I think it's something that we have run into, and I think that it's sometimes required readjustments, absolutely. Because sometimes when you get that swelling, all of a sudden everything looks off. But in my experience and what my therapists have told me, Vision RT is more able to actually adapt to it than marks, right? Because with marks, you're going to keep having the same problem when you get that swelling, whereas with Vision RT, you can actually pivot on the fly and adapt. So that's been our experience.
So you go back to the cone beam?
We don't cone beam, so.
Oh, you don't cone beam?
We don't cone beam, no.